Welcome to BizTech's Health and Wellness Show. Today our guests are from the Malaysian Medical Association. And our guest today is its president, Professor Datuk Dr. Subramaniam Muniandy. Now, welcome to the show, Professor.
Thank you very much.
Now, Professor, let's start by you telling us what MMA does and a little bit about its history.
Okay, MMA is more than 60 years old, and it has actually been, it is an association of members, so it has got no authority on any particular thing. It is just socially gathered members looking after the welfare of the medical doctors. It's not compulsory for a person to join MMA. So we have only about 30% membership from the total members of the medical profession in this country.
Which is about, the total number is about 80 plus thousand, am I correct?
No, 13,000 something. 13,000 plus.
So that is in private
the total
practice?
is about 80,000.
80,000, right? Yeah. Okay. And what has been the focus over the last couple of years? Because you are obviously just become the president very recently. But in the last 5 years, what has been the focus in terms of the MMA?
Now, in terms of the MMA, you see the things have changed quite a lot in this country too. So, for example, we have got too many medical schools developed in this country. That's MMA's view. We started this some years ago when the government was about to open up medical practice everywhere. All right. So we did object to some extent in a particular way to say that we must have a long-term plan if we wanted such a thing.
Yes.
But I don't think such a plan was really there. It just opened up, and we have got now doctors developing from about 30 odd medical schools within Malaysia. Private medical schools I'm talking about. Government has got its own. It's about nearly 8 or 10 medical schools that belong to the government. But the private alone has cropped up. And each year, we have about nearly 5,000 to 6,000 graduates graduating out of all this, which is our biggest challenge.
And one of the key things is, of course, there isn't enough spaces for them to be housemen.
Yes.
And I understand from my research that it takes almost a year for you to get your housemanship position. Is that correct?
It was, but now it's becoming shorter. It was about a year and a half, because of you see, housemanship, you cannot be placed anywhere you like. You must have a consultant supervising you.
Okay.
So all our hospitals in the country do not have consultants. There are consultant managed hospitals. There are some hospitals, especially the district hospitals, they do not have consultants in most of them.
Okay.
So when they do not have a consultant, then you can't place a house officer in that hospital, and he can only go there after he finishes housemanship. Now, what happened was, because of the large number of production,
yes,
we were not able to keep pace with the need for spaces for these fellows.
Okay.
So what we did was then went into waiting list. You passed, you wait until we get a space for you. This space was taking about a year and a half, almost 18 months to wait. Now, progressively, the government has been able to put more specialists in the number of hospitals, and the number of waiting time for housemanship now is almost coming down. Now it's about 6 months to 8 months you wait for housemanship.
And also, I think MMA has been quite proactive in this sense also, because you have a scheme called a Prehouseman scheme. Am I correct?
But it's not it's not a national thing. Some institutes have it, some don't. Like if you take mine, we have, after finishing your qualification, your MBBS, you have to spend some time called a pre-house officer posting to learn the art of being an houseman. The art of being a houseman can be stressful if you are not experienced. It can be very stressful. You are the lowest rung in the category of doctors. Course. Therefore, you get to be pushed around a little bit. I mean, this has been happening from my days.
But it's all the professions. Professor, at the end of the day, if you're an accountant, that's how you start. Yes. You're a pupil, or you're a lawyer, you're a pupil, basically, you're pushed around.
Correct. But the thing is, the medical profession is slightly different in the sense, these guys have gone and studied for 5 years. When they come out, they think they're already qualified doctors. Yes. They are qualified, but they don't have the experience. So that's been the problem. So when somebody comes and pushes you around, it can hurt.
Now,
it does hurt.
so how does the MMA feel that the government, for example, now coming back to a macro issue which is very current now, which is COVID-19, how do you think the government has handled the pandemic?
Well, I must say the government has handled this pandemic quite well. If you talk about the government, I'm talking about the health ministry. Now, I can't talk about the whole government because sometimes this pandemic is being created by them, by their movement. And this is a very obvious thing. I do not know whether it will come out or not.
Yes.
But I must tell you, it has happened. But I think the government as a whole has handled it quite well. But it has not been very smooth. We should have been much better. Our MCOs and our lockdowns, the first lockdown was a great success.
Yes.
The first lockdown for a short period of time was a great success. We almost brought down to single digit infection.
That's right.
But today, because of the Sabah election, I'm telling you this because the Prime Minister said it himself.
Yes.
Because of the Sabah election, we brought back and we are now dealing with 5,000. Now we are coming down again to just above around 1,000. But we were about at the 5,000. That was big.
Yes.
The infectivity rate was very extensive. But having said that, they introduced various things like SOPs. It's a compulsory thing. We made it. But then people also must understand. People don't understand the importance of SOPs. You know, to be able to... SOP is prevention of the virus. This virus, you cannot fight with drugs.
Yes.
You cannot do anything. You don't have guns, you don't have machine guns.
Yes.
So you must have something to prevent it from coming in. And this SOP was meant for that. Now the vaccination is to fight it. This vaccination, now we are having problem. Vaccination is being brought in. And there are people that there's not enough open discussion with the people. People should know what is this vaccination about. Why do you think people are now very reluctant to register for vaccination? A lot of people are reluctant.
So how would you do it differently from an MMA perspective? What do you recommend being done in terms of educating the public in terms of the vaccination and also the rollout of the vaccination?
Now, to me, I think if you want to look at the patient, you must look at it, not only the government sector should look at it. We have about 7,000 to 8,000 general practitioners in town. There are private hospitals also. Now we should use all their facilities. You don't use them, only government doctors keep doing this, I think it's a bit tough. It is tough because you are looking at a large population trying to be managed by smaller.
And so that's in fact the policy of the APHM as well, to essentially advocate that the private sector gets involved in the whole vaccination process from a registration as well as an administration as well. But are you in favor of also then the private sector being able to procure vaccines on its own so that we could have a faster rollout?
No, to me, I think the time frame is quite important. I think we really need to have a faster time frame. We just depend on one agency. It's not always easy. I don't see why. You see, the private sector is not as a money-making business. I think that is a misconception. The private sector is trying to help the government to roll out faster and try to get treatment faster. Who will go to them? Those big corporates. Big corporates who wants it early. Today, we put on the My Sejatra and people are waiting without even knowing whether they have been registered. People is registered. It's noted there, you are registered. There are people waiting for months and months not knowing what is happening.
No, and you've brought up a very interesting point about cost. Because one of the things that's happened, and on a different note, healthcare costs are rising dramatically, and especially on the corporate side. You know, when on a private hospital, when they see a corporate patient, the billing is different. I mean, that's always been the criticism. Healthcare inflation in Malaysia is above 10% per annum. Now, what can the MMA do to help the government in this respect, especially with the people who are underinsured and perhaps cannot afford some of these?
Now, to me, I think, you see, the government hospitals are giving everything for free. Everything for free. You can go and see a specialist for 5 ringgit. Not only consult, you also get your medicine for that 5 ringgit. And if you go to a medical officer, you get for 1 ringgit. Now, these things, people get used to it. So when they get used to it, they think you can get everything for 5 ringgit, why pay more? But the thing is, the practitioners, the private practitioners, they are not getting the medicine for free. Now, how does the government buy? They buy in large quantum for all the hospitals in the country.
And they also subsidize it tremendously.
Yeah, they subsidize it tremendously. And this cannot be done by private practice. The private practice is a business on its own. They have put up a building, they have employed people, they have got manpower to look after, they have electricity to pay for, they have the systems to run. So therefore, there must be cost to this, plus the expertise.
And also, I think that's part of the reasons why, because of that shift to government hospitals and facilities in the last 5 years, you've seen a dramatic number of GP clinics closing. Are there any other factors that have caused these large numbers of GP clinics to close in the last few years?
Frankly speaking, see, the government is trying to take on all by themselves. This is an issue that I have raised many times over. I think there are about 8,000 general practitioners in town. Forget about the private hospitals. And the government does not use them as they should use them. Where did these guys come from? All these 8,000 fellas. They're all ex-government servants. You have to trust them. If you don't trust them, you don't trust yourself. Is it not? Yeah,
yep.
You don't trust yourself. So you have to trust them and give them the same thing. What a doctor who qualified 2 years ago can do, surely a doctor who qualified 20 years ago can do there's nothing matching experience.
But then also, Dato, because one of the key things is it's about a balancing act between, so right now this system is unsustainable because the government is subsidizing, basically you get healthcare for free. On the other side of the equation, in our case, we have the private hospitals which are too expensive potentially for the average person. A lot of times, unless you have insurance or your company pays for it, or unless you're a T20 person, you can afford all that medical care. Now, is what you're advocating something like the gatekeeper concept, which is done overseas, where basically you go to a primary care physician first before you go to a specialist?
Exactly. This is exactly, it's been in my mind for a long time. Since I went overseas to study, I noticed that. That's the way it works. Then you must have a good gatekeeper system. The GPs are the gatekeepers. They call it your family doctors,
yes.
Whatever you want to call it by name. You call them, you see them, they will decide whether you need an opinion of a senior person, opinion of a person of a particular specialty. They refer. Now, what is going to happen? The GP is going to actually survive on that business. The government is going to reduce the cost of spending.
Correct.
All right. So, to be very fair, they should actually use that gatekeeper system.
But one of the things that then we need to do then, in order to have a middle ground and reduce the overall cost of healthcare inflation, is some sort of national health insurance scheme.
Yes, that is another thing I also have in my mind. If you look at Australia, for example, I am familiar with it because I was there. You cannot be in Australia without having a health insurance scheme.
That's right.
It's a government regulated health insurance.
Yep.
All right. So everybody is insured. Everybody is insured. You have to buy your insurance. It's not very heavy, but I can't say we didn't think about it. I can't say Malaysia didn't think about it. We thought about it, but we do not know how to implement it. Where do you get the funds from? Where you see the people pay so much, whatever insurance you pay may not be enough to still cover the cost. So they talked about taking EPF, part of EPF into this thing. They also talked about private insurance. They talk about this national insurance scheme. I think it's really a good scheme, which the government should adopt.
And the challenge with it is, of course, the complexity, as you just correctly outlined, the complexity of the implementation, because it involves so many stakeholders, and the challenge then is how to fund it correctly. Are you doing a risk? It's got to be a community-rated sort of risk profiling as opposed to a risk-rated, because otherwise, the private people will only want to, the private insurers will only want to insure the healthy people.
Yes. No. You cannot. You see, the thing is...
So it's got to be community rated. So means everyone has a flat fee, and that's what you pay for regarding it's taken off your salary.
That's right. Now, you want more, you pay more.
Yes.
Now also, that's what we do. You want to buy a bigger insurance to cover bigger things, you buy. But the basic things are all still covered by... Government actually covers major law, quite a lot.
Yes.
And we cannot say no. that we are known to be one of the best healthcare deliverers in the world,
Yes.
according to WHO standards.
And that's on a price to performance, what we spend versus what the outcomes are.
Yeah, it's simply because we said that our Malaysia is one of the rare countries where the healthcare is delivered to your doorstep by our public health services all over the country. We have got health clinics everywhere, government health clinics. Only the problem is, how much do people want to go there? When you want to go to private, unfortunately, it cannot be as cheap as the government.
Yes, of course.
It has to be. Because it's an investment policy.
And the only way that happens again is an insurance scheme.
Insurance. Yes.
But Dato, you're the premier representative body for the private sector doctors in general practice. How do you make sure, as an organization, that your doctors keep up with what's happening in the world in terms of medicine? What sort of CME programs and stuff do you do in order to upskill them? Because medicine is changing rapidly.
Yeah, true. But this is now become also compulsory by the government. Nowadays, we have this CPD system, where if you don't have enough points in your CPD, which you collect by learning by yourself or learning through webinars, attending meetings, so that you upgrade yourself. If you don't have enough points, you don't have a practicing license for the following year, which is one good thing. It is a compulsory thing, and I don't think the quantum of points required now will stay that way. I'm sure it will go up. Now, as an organization, we have also organized many webinars on this. So we will cover this. We organize scientific meetings. We organize conferences. Not only we. There are various bodies organizing various conferences. So people must attend this, and they must keep pace with it.
And how are you as MMA doing this? Because when we did our research in terms of your website and social media, there isn't a lot of engagement that you're doing right now. How are you evolving yourself so that you're more digitally orientated to the needs of the market today?
Okay. Now our digital system is now picking up. Now it wasn't there before. Now it's been picking up. We are now trying to go mostly digital. Now all the webinars almost on a daily basis.
Okay,
Almost.
but where is that stored on your website? Because it's not very clear.
No, the thing is this. Now at the moment we have got a thing where we can actually anybody can go in and find out.
Okay.
It not necessarily applied to only MMA. It applies to everybody. We are allowing all doctors to come in.
Okay.
Which personally I think you should control, because otherwise people will not be able to will not join our membership fully.
Okay, so Professor, one of the things which people have criticized in the past is sometimes MMA is too social and not providing enough thought leadership and not engaging the government enough. So one of the criticism was, for example, a lot of say technology organizations and all that, when they want to engage the government, they write a white paper, they write a position paper, and they forward it to the government. So the government takes them seriously. Whereas the engagement with MMA is less on that sort of level. How are you going to change this? Because your last paper that I checked on your website was on medical ethics, and it was from 2009. So how are you going to change that?
Okay. Now you see, now we are beginning to become more conversant with more associated with the ministry, government. We are trying to talk to them. We are trying to tell them, look, you must engage the private as well as government doctors into one big group, so that they all grow up together as one thing. And the government is now beginning to listen. They are just beginning to listen. They are trying to take note of the fact that there is some definitive advantages in this business. And for that I must thank COVID. Since COVID, we were able to carry this message stronger, to tell them, look, you can't leave the general practitioners outside, use them all. And because of this thing, every day there's information coming out from various talks and seminars, from various specialities, various systems, and a lot of things. We can take a cow to drink water, the cow must drink.
Cow must drink it.
That we cannot do anything about the cow.
Yes. And so that one of the things is how, which comes to technology again, what is the MMA pushing for in terms of digital health? Because now we've got, and for many years, 5 paperless, filmless hospitals, which is Sungai Buloh, Putrajaya, and so forth. How are we taking this forward on a GP level? What are you doing?
No, at the GP level, we are trying to promote digital health. Now we are trying to say, be conversant with your patients, follow up with the patients on a digital line if possible. If call them, speak to them, get what do you call computer. You get onto the computer, you follow. Even on COVID, we have suggested that they can follow up the COVID patients in their house through the internet. You don't have to be going, but we will follow them up. You know, so it is one of the things that we are pushing for is a digital health. We are hoping so it becomes easy so that people don't have to come. One of the things I am also discussing that at the World Medical Association, we are also discussing digital health. Digital health comes from many different forms, but one of the things about we are discussing is equity. Are people able to follow? Are the general people, you can say whatever you want, do they understand technology? This is one of the problems. The good thing is the younger generation are able to help, but the older people do have some difficulty with. Now even you take Sajatra, my Sajatra, they say register.
Yeah, it's tough.
It's tough.
If you're older, it's tough.
It's easy,
Yes.
not easy. I found it tough myself.
Yes.
So I tell you, so these kind of things are a little difficult, but it will take time. It will take time, and I'm sure we will get there.
Now, any final thoughts you want to leave us with, Professor?
To me, I think see the thing is, for the senior doctors, the general practitioners, I do think the government should merge with the government. Can't merge in the sense, don't take them and put them in hospital. Use them. That is expertise available in the ground. Use them. Use them to manage the patient. Now you took at some patients don't need to go to hospital on a follow-up on a monthly basis, 3 monthly
Because
basis.
telemedicine can solve that problem.
Solve that problem very easily. Even it's a direct consultation. You can
Yes.
do it if you use the general practitioners.
Yep.
You don't have to crowd the the government hospitals. But the government must be willing to let go of this what you call non-communicable diseases thing, which is not communicable. That means they get follow-up once in 3 months, once in 4 months. They collect the medicine. Now, if they think the medicine is wrong, we have even suggested that let them consult their own GPs around their area. Now, around the area, that because we are supposed to be world's leading medical providers by taking medicine to your home.
And also one of the things is it goes back to that whole old concept, but good concept of having a family doctor.
Yes, it is. That's what I suggest. That Australian fellows, they follow it very strictly. You must have a family doctor. You choose your doctor in your area.
Yes.
You don't choose your doctor in the next town. Today, in our country, you can choose any doctor anywhere.
Yes.
You know, so this is a problem. So, and I think if you have a family doctor, then the family doctor learns about you more. You learn about the doctor equally. So the confidence and the relationship between the doctor-patient is definitely much better than you one day going to this doctor, next day you go, you see another fellow, third day you see another fellow. This fellow doesn't know what happens then. We have failed in one of the things. As I just told you earlier, my card has got a chip to carry
Yes.
a health record.
That's right.
But the health record is never there. It never got in.
It never got in.
There is a chip there, but that's never got in. I asked even to the guys who would design that system. You know, that should have been there.
Yes.
So it doesn't matter then. It doesn't matter which doctor looks at you.
Yes.
The records are there. But definitely, they cannot give the written records to patients. It is not possible.
Of course.
They are medical legal documents. They are documents that needs to be kept. Today, if anything were to be happening, any legal suit against anybody, those are the records that we depend upon.
Yes. On that note, thank you very much, Professor Subramaniam, for taking the time to speak to us.
Thank you very much. Thank you.
I'm Brian Fernandez, and I've been speaking to Professor Datuk Dr. Subramaniam Muniandy on BizTech's Health and Wellness Show. Please check out our Facebook and LinkedIn pages and subscribe, or check out our website at www.biztech.asia for business and technology conversations.